Well, appreciate that introduction there, Dr. Joachim. I actually didn't know I'd be stepping up here right in this minute, and I certainly didn't know. He said he wrote a biography about me, and I gave him 5 lines that he could have used, but I really appreciate that. It's a real honor to be able to speak to you all today. I have been in the market here for 10 years between BAMC and Wilford Hall. It's really great to see, multiple prior fellows all giving lectures here, current fellows, and even potentially some future fellows that we worked with on consult service this week. So what I'm going to be speaking about are management of foreign bodies and food impactions. And as Dr. Edelson mentioned, I also do not receive money from anyone but the federal government at this point. That'll change next summer. When I retire. I'm not going to any other big business. But yeah, here's kind of my pipeline. So I did do my fellowship at the University of North Carolina, and I learned ERCP, EUS, single balloon, those sorts of interventions before everything got really wild, like what these guys can do up here. But before I started learning that, I actually found that foreign body was probably my favorite thing. In fact, I probably would have done a fellowship in foreign body if I could have. And I'll have to learn from some of the people who are fellows at community or city-based hospitals. But in North Carolina, we were the hospital system for the prison system as well. So we saw a lot of interesting things that we haven't actually seen too much of with our TRICARE beneficiaries. So I had a ton of experience in foreign body as a fellow. Now, I'll be honest, most of my experience since then would be more with food impactions, and we have a huge cohort of EOE in the military. So some of this is kind of old. I don't have fancy videos like Dr. Edelson because, well, we did have video back when I was a fellow, but we weren't thinking to capture all these interesting things we're doing. After North Carolina, I did spend a tour at Elmendorf, and then again, the 2 facilities we have here in San Antonio. I'm going to start with a case of a 41-year-old male with prior foreign body. He presented with attack ingestion. Interestingly, while I met him in North Carolina, he was from 5,500 miles away in Anchorage, Alaska. And when I got to Alaska as my next tour, he was pretty famous up there as well. So he came in and he had said he'd swallowed tack, so we got the ER got an abdominal x-ray, and here we can see multiple, tack-like foreign bodies in his left upper quadrant. He also has a couple clips in the stomach from probably the last time they had to intervene on one of his foreign bodies. So here's what things look like endoscopically, and this, after you're removing spatulas and knives and razor blades and things, tacks didn't seem like that big of a challenge. And we were to remove everything we saw, but we were fairly certain that the x-ray had shown 5 tacks, not 4. And so this is the x-ray after that first endoscopy. And you can see there is still a foreign body in the left upper quadrant in addition to those 2 clips. So what we realized when you look back at that initial x-ray and you see those 5 foreign bodies and you compare that to post, what you realize is it was the transverse colon superimposed over the stomach, and one of those had already traversed well beyond the stomach. So this is a sort of patient we got daily x-rays, followed very closely. He was the type of patient who could pretty easily increase his heart rate to 150, so everyone was always kind of thinking this tack was getting ready to come through the colon. But here was an x-ray a day or 2 later where he's getting ready to either have an asymptomatic or a painful bowel movement. All right, so this is my 15-year experience. Here's the foreign bodies that I've removed: pens, ink, pencils, spoons, forks, sporks, knives, razor blades, spatulas. Typically they do have to kind of crush down the thick part of the spatula to get that one down. Toothbrushes, picks, et cetera, et cetera. And you can see all of these things. Earrings, that was a patient, not intentional. But most of these, again, are. A chair balance would be like something that keeps your guys' chairs balanced on the floor. And so, again, when a lot of these patients are coming in from prisons, they don't actually, or mental health facilities, they don't give them access to things that they could swallow, but they'll still find it. And then here's food impactions: chicken, Cornish hen, steak and beef, state fair turkey leg, no doubt, hot dog, sausage, pork, crab meat, a lima bean, fish bones, pills. There are probably others, but this is what I could come up with off the top of my head. And while I'll say chicken is the most frequent, probably the most difficult I ever dealt with, there was some tough steak, but the crab meat filling the entire achalasia esophagus was quite a challenge too. This is not my own collection, although at UNC we do have a museum of all the foreign bodies that we had removed, and I never thought, wow, I should have a picture of that. But this is actually from the European Foreign Body Guideline, and this is just one provider or practice's kind of snapshot of the things that they've removed, and gives you an idea of the sorts of challenges that you're going to have to encounter as GI fellows and GI faculty. I do look back at our guidance. Now this guideline, the ASGE guideline, is from 2011. It's actually the oldest upper GI guideline in ASGE, so maybe it's due for a reset, but I guess a lot of this hasn't changed too much. And then the European guideline on the right. What I'll tell you is, again, I'm dating myself, but that guideline on the left wasn't out when I was a fellow, and I always thought, you know, it was kind of just figure things out. I do think it's a fairly nice document that does kind of walk you through a lot of how you're going to approach patients with foreign body and food impaction. Also looked to the emergency department literature and didn't find a ton, but that's going to be the main place where you're going to actually get patients with foreign bodies and food impactions, more so than internal medicine, primary care, or other referring bodies. And this is one of their guidelines that mostly talks about imaging for foreign bodies. And it walks through, for swallowed foreign bodies, kind of the same approach that our guidelines mention. So they don't talk a whole lot about treatment other than get an image and call the right specialty provider to get things taken care of. As far as epidemiology of foreign bodies, so the majority are in pediatrics, and the peak is 6 months to 6 years. These are often kids unintentionally putting items in their mouth, swallowing, and then having panicked parents bring them to the emergency department appropriately. In adults, mostly are intentional, and those are in patients with psychiatric disorders, developmental delay, alcohol and drug intoxication, incarcerated individuals and secondary gain, and by that it's, you know, patients who are wanting to get out of jail or prison, and they know that they're probably going to get significant sedation, potentially fentanyl, and so multiple and repeated episodes is common, and that's my experience by far. And then edentulous adults can certainly, you know, they're more likely to have impactions of foreign bodies or prostheses because they can't chew, or they have prostheses so they can accidentally swallow those things too. Historically, most foreign bodies will pass without intervention. With intentional ingestion, a vast majority will require endoscopy for removal, and only 12 to 16% as of that 2011 guideline require surgery. I think that's fairly high. I didn't have a whole lot in my experience who proceeded on to surgery. The mortality at that time was 0% in the reported literature in adults, and 1 out of over 2,000 children. As far as making a diagnosis, most patients will actually tell you, I swallowed a knife, or they'll let, you know, they come in letting you know what's happened. I did have a patient one time who was doing needle point and swallowed the needle. So again, they're going to be able to tell you what happened in children, and again, those other populations, they might have choking, vomiting, refusal to eat, wheezing, secretions, those sorts of symptoms. Your exam primarily is going to require excluding somebody who needs surgery, so making sure they don't have crepitus, neck swelling, or the abdominal exam that makes you more concerned that something is already perforated through. X-rays are reasonable for foreign bodies, but not most food impactions. It's not really necessary if somebody reports that a huge plug of chicken and it's now stuck in my esophagus. The X-ray isn't going to probably see it or help you much. As far as foreign bodies, or as far as X-rays, it will see most foreign bodies, kind of depends on the material, and then it'll see steak bones and obviously free air. But as far as fish and chicken, wood, plastic, or fish and chicken bones, wood and plastic, glass, thin metal, a lot of that can't be seen on X-ray anyways. And then avoid contrast for many reasons. One, you're going to actually add contrast to the foreign body you're getting ready to remove. Two, it does increase aspiration risk of a substance you don't want going in their lungs. So it is generally recommended not to do any contrasted studies for foreign body. Now, as far as management, of course, we always start with airway and ventilation status. So especially if it's a high foreign body, or if they're having a lot of difficulty with secretions, then you're going to have to significantly consider intubating the patient. You're also going to consider that for some proximal foreign bodies, just because of the difficulty of accessing it if they're under moderate sedation, and you don't have protection of their airway. Difficult objects or multiple objects. So I think if you've got a stomach full of objects, you just want that patient asleep, because it's going to take you probably a couple hours to remove. And then for rigid esophagoscopy, which of course we don't do, but for ENT, and you will encounter cases where both you and ENT are involved, and you're trying to figure out who's the best service to remove options. Often you'll both take an opportunity. And most adult cases of foreign body ingestion may be managed with conscious sedation. This is printed again in this 2010 guideline. So I did an entire fellowship of EUS, ERCP, single balloon, et cetera, largely with moderate sedation, but things have changed a lot in the last 12 years. So I know you guys get to consider deeper sedation for almost everything, which is ideal. All right, as far as timing of endoscopy for ingested foreign bodies, this is probably when you guys get calls next weekend when you're on call and you have a foreign body, what you're going to want to resort to, like, do we need to come in and do this now? Is this a Saturday or Sunday thing? Can it wait? As far as emergent endoscopy, so our guideline says that you need to emergently come in and remove remove a foreign body from the esophagus for a complete obstruction, disc batteries, and then sharp pointed objects in the esophagus. So all of these are esophageal. So if it's gotten to the stomach, then there's a decent chance it's not immediately required. As far as the European Society, they concur. It's the exact same 3 indications. So a complete obstruction, a sharp object, or a disc battery in the esophagus. And they actually give a time frame, which is 2 to 6 hours. So that means come on in, and let's probably let your staff know that they're going to be coming in too. As far as urgent endoscopy, so esophageal foreign objects that are not sharp pointed, so maybe it's like the chest piece or something like that, or a spoon, food impaction, but without complete obstruction. So people are getting secretions by. They can typically wait a little bit. Sometimes it'll even pass on its own if you give them some time. Sharp objects in the stomach or duodenum, I would say, most of the time, I think if you want to get it, you kind of go in and do it. So if you wait, there's a decent chance it's going to pass, but both societies are okay with calling that urgent and not emergent. And then objects that are long above the proximal duodenum. So if you do have, let's say, a spork or spoon or something that's not sharp and you're not concerned about in the stomach, you don't need to come in immediately. And then they do say magnets within endoscopic reach, and that's not because you're concerned about them obstructing as much as being in 2 different parts of the intestine and actually connecting and then causing ischemia or even necrosis between the 2 magnets. And again, the ESGE with a newer guideline concurs with all of that. It's basically the same sort of indications would be urgent. So not necessarily 2 to 6 hours, but more of the first 24 hours. And then they say basically to do a non-urgent endoscopy for anything else, like medium-sized blunt foreign bodies in the stomach. Because again, a lot of those will pass on their own. And then this is the ASGE guideline for non-urgent. It's coins. A lot of these, basically they say stomach, foreign bodies greater than 2.5 centimeters, non-sharp stomach, foreign bodies, et cetera. If endoscopy is not pursued, it's reasonable to just observe most asymptomatic gastric foreign bodies. They should pass in 4 to 6 days. You just keep them on a regular diet and observe their stools. In the absence of symptoms, you get a weekly x-ray to make sure it passes. We do have evidence for our own foreign bodies. Some examples, actually Dr. Edelson talked about a whole bunch of them. Perhaps a migrated stent, right? A metal stent. We know that sometimes those will pass on their own. And then we obviously place all of these, so smart pills, capsule endoscopy, Bravos. We're putting foreign bodies in patients, and we know that the majority of these pass without incident. So again, items that are smaller and non-sharp, you can typically observe. As far as the equipment you'll need, so if it's a rigid esophagoscopy, so that would be for hypopharyngeal or items by the upper esophageal sphincter, that would be ENT with a rigid scope. For us, we're going to use flexible scopes. I think standard are fine most of the time, but it's good to have therapeutic available. There have been cases reported with the ultra-thin transnasally. And then you're going to want to consider all sorts of retrieval devices, so you can put caps on the end of the scope to help suction things, all sorts of forceps, snares, graspers, baskets, nets. I'll tell you, Roth nets or other sort of retrieval nets have been one of the most successful things for me. I use a lot of snares as well. A foreign body protector hood, we don't actually have this at BAMC, and I'm curious to know if others do, but this was an absolute necessity when we were doing a ton of foreign bodies back in the day. And then over tubes. And we actually had, at North Carolina, had taken like a suitcase that you would usually send this broken scope back to Olympus, and it was filled with foreign body devices. So I knew, having to set up an endoscopy, because we didn't have techs do that back in the day, if it was a foreign body, I just grabbed that suitcase on top of the cart and off we went. And I knew that it would have all of these devices. So that's a pretty reasonable thing for someone who's going to see a good amount of foreign bodies. Here's how the foreign body hood works. Does anyone have this? Do you guys know? Anyone who does a lot? Yes? Okay, good. So you put it on the end of the scope, and as you're advancing the scope forward, it's kind of flipped backwards, so you're not really seeing it, and it's not bothering you, it's not in your way. You can go, and as they give that example with a safety pin, you can go and grab it, and then when you come back to the lower esophageal sphincter, and as you're pulling back, that hood will usually flap over the sharp foreign body to protect your esophagus on retrieval. Very, very helpful item for sharp foreign body. Over tubes, probably use this a lot more for food impactions, but certainly can be used. Of course, your foreign body is going to need to be able to fit through the over tube, but you backload this tube onto your scope, intubate, and then you can advance the scope so you can go in and out, in and out. So maybe if we had somebody who took all the little leads out of like a dozen pens and swallowed all of those, well, this was ideal because we could grab those from the stomach and pull them out one at a time, and they could fit through the over tube. And then tons of devices. These are pictures from the actual European guideline of all the sorts of things they think about: alligator forceps, shark forceps, rat tooth, and a lot of snares and baskets. So they can be very helpful to you to figuring out different ways to grab different parts of the devices. And I still have a few prototypes in my mind, but I've always been told if you have an idea for an invention, don't let anyone know. So back when I was doing this a lot, even some of these made some things that we'd have to retrieve somewhat challenging. This is an Olympus device called the e-suction. It's a cap with a little snare embedded, which kind of helps just pull helps pull every little foreign body in there. Here's them grabbing a hypothetical thumbtack, how that would work. So a lot of proprietary things out there as well. Shifting briefly to food impactions, this is something you probably will see even more frequently. Certainly we do in the military. Most frequently food impactions are meat. As far as food extraction, and again, we didn't have this guideline when we were doing foreign bodies, and we have a huge EOE cohort at the University of North Carolina. So we were kind of just figuring it out each time on its own. And it was really taught back then not to ever try and advance a foreign body into the stomach, because you didn't know what was on the other side, and it was thought that increased the risk of perforation. So as far as food extraction, there's end blocks, so you can grab it in one big bolus. You can use a snare, a net, banding cap, or you can do a piecemeal approach where you have to kind of break it up and take small pieces. And now there is the second, which is advancement of bolus into the stomach. As I mentioned, the ASG previously advocated against this. They said do not do this because they thought it increased the risk of perforation if there's, let's say, a tight stricture or ring on the other side of your foreign body. But in two large case series, there were 0 perforations. So now they recommend gentle pressure to the center of the bolus. And then if you have to reduce the size of the bolus by doing a little bit of piecemeal, then you can continue to try to kind of gently push at the center of the bolus. Reasonable approach for removal of food impaction. And they do mention that glucagon is okay, but don't delay the endoscopy. We know most of the time the ER will try this. And it's not that it never works, it's just make sure it's not preventing us from getting a specialist in there to remove it. This was a hot dog impaction in an EOE patient at North Carolina. And so this one, we obviously took a look. We ended up deciding to use a cap. I don't have video or anything, but, and again, this was most likely an extraction rather than pushing this into the stomach, especially with a cap on the end of the scope. This one we had, this is one of our current fellows' first food impactions over at BAMC. And so again, a EOE patient, a known EOE patient, somehow took a number of sort of big bites and a bunch of pills kind of simultaneously. So we started encountering these in the mid-esophagus. And so rather than the anesthesia team elected to intubate him, so we had airway protection. So we actually started in the mid-esophagus, and we were using a net to bring things back and extract things. I would say, as Dr. Edelson mentioned with choledocholithiasis, if you have 10 stones in a bile duct, you don't want to start above the 10th stone and try and pull them all out together. You want to start low and grab one at a time. The same thing would apply to a food impaction. If they have a ton of food, you're going to have to start high and just remove it slowly and methodically. This is a 58-year-old who had a food impaction. She had kind of a mishmash of food, so we weren't quite knowing what to expect, and she had a history of radiation esophagitis and a stricture. So we encountered a single lima bean just perfectly impacted in her proximal esophageal stricture. I tried to snare this, but it just wouldn't grasp it, and then it wouldn't crush it either. So we ended up using, a big forceps, kind of crushing it, and then we actually just put the forceps in the middle, and we were able to push it into the stomach by having a little bit of purchase in the middle of the food impaction. Here's how I do it. I think MAC is ideal, but I've done most food impactions in my career with moderate sedation, so that works if you have to. Start with an endoscope. I don't start with a cap because I want to have kind of the thinner scope in case I am going to be able to push it or even work around a foreign body to see on the other side of it. But I have caps, therapeutic scopes, and obviously devices available, and if you have that suitcase full of devices, that'd be really helpful. Suction really well before encountering the bolus. So if the patient has half their esophagus full of secretions, you want to try and clear this, and it's going to continue to drop on top of you as you remove foreign bodies. So really get them suctioned, because once you have a device out, you lose a lot of that suction, especially with a regular scope. That's one of the reasons why therapeutic scopes can be really helpful, because you can have a device down and have really powerful suction as well. If you have high or extensive food, intubate and or use an overtube. So if I ever put in the scope and I see food as soon as I get to the UES and I know the whole esophagus is full, I pull the scope out immediately and say, let's intubate. We don't need an aspiration of food. The patient could get really sick, obviously. I try a gentle push. If that doesn't work, my preference is end block. Potentially with some of these devices, if that doesn't work, then we'll have to remove it piecemeal. And that very well could be the most common way, especially for larger impactions. And then as far as foreign body, I recommend a hood for sharp objects. We see them very rarely in the military, so less experience with that recently, but I'm glad to know that those are still available and being used. And then consider a suitcase with devices. And we don't need to go through all of this, but the ASG guideline does have a nice 1 through 10, basically kind of reiterating all of those things. Avoid contrast. The one thing that both guidelines mention that we didn't say, and I've never seen, is they recommend against removal of drug packets. I think there's concern that you could rip those open and lead to a sort of devastating overdose there. And then same thing with the ESGE. Very, very similar as far as guidance goes between the two societies. So this is actually not the sun setting, or the sun, yes, setting. It is the sun rising. But I think some of you guys who have experience at Wilford Hall be interested to know they are finally, after we moved out of this building in 2017, taking it down. So one less medical facility on the horizon in San Antonio. Appreciate your time. We're doing questions later. Yeah. Awesome. All right. Thank you all.